So we're here today examining Sage, who is an 8-year-old female spayed bully breed dog who is presenting to us because she has a history of being painful in her hind limbs. So we're going to go through an orthopedic exam today. The orthopedic exam actually starts the minute they walk into the hospital. So when they walk in, I'm actually watching to see what legs they're favoring, how badly they're favoring them, if they're using them at all, and see if they actually have more than one limb that's affected. So the owner doesn't always speak the same language that you and I speak, so a right leg to them might be their right hand as they're looking at the dog. Whereas it is not the dog's right, which is how we usually classify it. So you're verifying that the correct limb is the one in question. The next thing is I'm just looking at the overall appearance, and Sage actually has some really nice padding on her. So when I look at her, she has a body condition score of 8 out of 9. So she has a really good covering over her ribs. She doesn't have a really defined waist, so that would be definitely one thing to note for your plan management. Going directly to the orthopedic exam, you have a couple options. You can examine them standing up and you can examine them laying down. I find advantages in both positions, so I do a combination of both. Since Sage is already laying down for us, we'll start with the laying down part. I tend to choose the limb that is least painful to start with. You lose their trust quite a bit when you make them painful. So for Sage, that's her front legs. So we're going to start with her front leg. And the first thing you want to do is actually start at the bottom and just look at the toes. You don't even have to touch them to start with. Just checking to see, are they there? Are they trimmed to an appropriate length? Do any of them look swollen or painful? Because even a nail bed infection can cause lameness. After I've looked at them, then I'm actually going to look at the pads. So I turn the pad or the paw over, look at the pads, make sure there's no wounds on them, check between the pads. So I'm actually kind of spreading her toes apart, make sure there's no masses or wounds in between there. And then I'm going to put pressure on each of the pads to make sure that those are not what's causing her pain. I'm also going to palpate each digit to see if I feel any swelling or discomfort in her digits. And then I will put her digits through a range of motion. So I will flex the toes like so, and then extend the toes like so. If I felt like I got pain in a specific digit, I'm going to go to that digit individually and do those to see if I'm getting pain there. Next, I'm working up the metacarpals. So I'm putting gentle pressure on them. 1, to feel for any swelling, and 2, to see if she's painful as I palpate them. Next, you've got the carpus. The carpus has a pretty good range of motion, so they should have a 180-degree extension at a minimum. Much more than that, then I get worried that you actually have some laxity. And flexion is pretty significant too. So a really flexible dog, like Sage, can actually touch the back of her arm with her pads with no discomfort. The carpus is also a very good joint to feel if there's any effusion. So you should be able to feel little divots in between each of the carpal bone really easy. If you feel any fluid above that or any swelling above that, that's a good sign that there's effusion. From the carpus, we're going up the radius and the ulna. Again, I'm putting gentle pressure on the bone, trying not to trap the soft tissue in between it, to see if she has any discomfort on the bone directly. And then I'll come back up and just kind of squeeze my way up to make sure there's not a mass or any disfiguring problems in the antebrachium. That leads us up to the elbow. The elbow is actually buried in soft tissue above and below pretty well, but if you feel over the condyles of the humerus, you should get directly to bone. If you're going to feel effusion, it's usually on the medial aspect. So I put my finger on the epicondyle of the medial aspect and just feel around that surface. Make sure I don't feel a little bulge kind of rolling under my fingers, which would be a sign that there's effusion. I'm also going to put pressure, again, on the bone, not the soft tissues, to see if I get any pain or reaction feeling those epicondyles. The other part of the elbow is actually the olecranon back here. So I'm going to feel up that. Presumably I've already felt the triceps by the time I've gotten up there. So put a little pressure on that, make sure there's no discomfort or swelling there. Next, we're working our way up towards the shoulder by the humerus. So I'm palpating along here, make sure I'm not getting a reaction of the soft tissues as I go. This is also a really good time to actually feel their armpit. Make sure you don't feel a mass there or anything uncomfortable in that space. Elbow should have a range of motion that's pretty extensive as well. So carpus kind of comes up to their chest without any discomfort, and elbow distends to about 180, or extends to about 180 degrees. After I've palpated all of the soft tissues, I'm going to feel a little bit deeper. So I'm actually palpating the scapular spine to make sure that there's no asymmetry there or disfiguring of the spine. Make sure they're not uncomfortable as I palpate that. And then work my way towards the shoulder. So right up at this point, it's actually hard to feel the bones of the shoulder because they have so much soft tissue covering. You can typically palpate the biceps tendon, especially in a dog that's in really good working condition. You can get a finger around that. And I will actually put a little pressure on that as I'm palpating the shoulder just to make sure I'm not getting a reaction. For shoulder range of motion, it's really hard, you'll notice, to distinguish elbow from shoulder when you're manipulating them. So to actually get shoulder flexion, you can come right in front of the elbow, and I'm kind of stabilizing the scapula with my other hand and pushing them towards each other. To get even better flexion, I can hold the anabrachium and push it up, but you'll see I'm also flexing the elbow in doing so. For extension, I put a hand right in front of the scapula and the humerus, and another hand right behind the humerus, and I'm pushing straight forward. And you'll notice automatically the elbow is going to extend as I do that, so you might get some discomfort just from that elbow extension. Sage is doing really well with her front leg, not very painful there. Now we're going to move to the part that is a little more uncomfortable, which is her back leg. So, hi, sweetie. Hi, sweetie. Why don't we actually have her stand up for this part? I'll have her face you. I think she'll be a little more comfortable. So even though Sage is not happy with her exam, you can see how well doing the exam worked when you have somebody that's really skilled at holding her. When they're in lateral recumbency, it gave me a lot more ability to actually flex and extend the legs without her fighting me. The advantage of them standing is I can actually palpate both legs at the same time and compare and see if there's any asymmetry. So when I'm doing the standing part of the exam, I'm actually running a hand down the limbs. This works for both front limbs and hind limbs. And I'm checking to see if the muscle tone and bulk is the same on each side. And in Sage, it actually isn't. She has some differences between the muscle tone and bulk of her quadriceps. And that'll help clue you in as to where some of the problems may be right off the bat. I'm also feeling for any masses as I'm going and feeling for any effusion. So in the hind legs, I start up at the hips, just gentle pressure as I'm working my way down, move to the inside of the quads, feel that. And then I've got my fingers on her stifles. And I can feel for effusion fairly easily and tell very easily if there's a distinction between the two stifles and effusion. Again, keeping gentle pressure, I'm palpating down towards the tarsus to see if there's any effusion, comparing each side and kind of working my fingers over those to see if there's any fluid kind of moving or bulging beneath my fingers, and then finally down towards the toes. Hind limb, same story as the front limb. You're going to start with the bottom of the foot, make sure that there's not problems there. You will notice if I do the exam in standing, I have to actually put the whole leg through more of a range of motion to get a look at the whole part of it. So that's why I generally prefer the lateral recumbency for when I'm doing my full extended range of motion exams. So her pads look really nice, nothing between the toes. Flexion and extension of the toes are the same. Then I'm working up the metatarsals towards the tarsus. Again, palpating to see if there's any effusion or masses there. Tarsus, you're gonna feel the condyles of the tibia. I feel the cranial aspect of it, and then I work my way back towards the talus. From the talus, you can actually follow the Achilles tendon up. It should be a nice, very tight band without any discomfort as you're palpating it. And then I put a little bit of pressure right where it inserts, or part of it inserts at the talus, and make sure I'm not getting a reaction of pain there. For range of motion of the tarsus, flexion, you can see how the knee is actually starting to flex as I do it. That's a normal reaction. You get less of that flexion when they're in lateral recumbency. So they should be able to do about a 90-degree angle. Doing that, I can actually see her foot kind of pulsing like that. That tells me I'm getting some discomfort somewhere. It may not be her tarsus because she's not reacting to it, but I am causing some discomfort. Extension of the tarsus is about 180 degrees. From tarsus, I move my way up the tibia. You start getting muscle groups here, so I palpate those muscles, make sure they're not painful or uncomfortable. Up towards the stifle. Stifle, again, we're checking for effusion, so you should be able to feel the straight patellar tendon really distinctly if it's a normal knee. And with Sage, she actually has no distinct patellar tendon because she has effusion within that knee, and she has a bunch of bony remodeling on the medial aspect that I'm palpating as I go. For the knee, there's a few things you want to check. You want to see if they actually have luxating patellas. So I have my finger on the medial aspect of the patella. I'm putting pressure towards the lateral aspect to see if I can pull that out of the patellar groove. And then I switch sides, so pressure on the lateral towards the medial side, see if that can move. If you have a high index of suspicion that the patella is the problem and you're not getting it to move, putting the joint through a range of motion can actually help. So if I didn't get any movement, I will do slight flexion, again, pressure on each side of the patella, and slight extension, pressure on each side of the patella. No movement for Sage today. So my next suspicion is going to be cruciate ligament. So I'm just going to check overall range of motion to start with, and I'm going gentle here. I'm not trying to make her scream, so I'm just going slow. If she tells me it hurts, I stop there. I don't need to go farther than that. So you can see she's a little resistant as I do flexion. The extension is the part that's probably going to be most uncomfortable for her. You can see she's kind of stopped panting, her head's come up, she's concerned about that. So she does have pain on the extension. So we're looking at Sage's stifle right now, and we're checking for cruciate instability. So I'm going to do the cranial drawer test first. I have my fingers on her patella up here, my thumb on her fibula back here, and I'm just holding the femur still. I will move the tibial portion to check for drawer. For distal part, my fingers going on the tibial tuberosity and on the fibular head, and then I'm obviously very painful, and I am just trying to move the tibia relative to the femur. And she actually does not have any instability. With the amount of remodeling I have on the inside, that's probably because it's fibrosed. Next, I'm checking for tibial tuberosity thrust. So I like to have a finger on the patella just so I have a point of reference. You can see the sharp angle right here is the tibial tuberosity. So I watch this point relative to my finger, which is on the patella. I put my hand on the tarsus, and then I'm going to flex tarsus 90 degrees to see if the tibial tuberosity moves relative to the patella. And she does have slight thrust there. Whoops, we're okay. And that's the extent for checking for the cruciate. For the hip, it's just a matter of flexion and extension. I do want you to see as I extend the hip, the stifle is actually going to extend right along with it. She got decreased range of motion back here, so she might have some hip osteoarthritis that's contributing, but you'll notice she's not nearly as protective of it. For flexion, she's actually flexing it really well on her own. So knee should be able to come up to about the middle of their back, And again, you'll notice the stifle is flexing along with it. And that about does it for your orthopedic exam, other than doing the other side.